Thank you, Ajay. So in the next 14 minutes or so, I'm going to cover imaging, lasers, and steroids. So first, let's talk about the imaging. So what do we want to see when we are imaging the retinal edema in diabetes? We want to know the thickness, we want to know if there is a subfoveal detachment, we want to know cystoid macular edema, so we all understand OCT is the best modality for that. We also want to see what is the component that is leaking and what is the amount of the ischemia that have. And there is no way OCT is going to show us, and we do understand that our age-old fluorescein angiography is still the best modality to look at the microaneurysms as well as to look at the areas of non-perfusion in the periphery or in the macula. Like Dr. Atul said, and I'm going to show, we are looking more and more at the areas of peripheral capillary non-perfusion, and we do need a wide field angiography for that. So imaging actually, and then we have this new tool on the block that is angio-OCT, and I'm going to show you a couple of imaging from the angio-OCT and how it is helping us. As mentioned by the previous speakers, it's important to know whether we are dealing with the center involving or the non-center involving diabetic macular edema, because in center involving we prefer pharmacotherapy, whereas if it's non-center involving we could think of doing the lasers still. So now if we look at this, whether the center is involved or not, we go for the fluorescein angiography. And on fluorescein, we do see the microaneurysms which are away from the fovea. And we now can do angio-OCT. Now here I would like to say that angio-OCT is nothing. It's just a new generation OCT where you can actually measure the blood flow within the blood vessel. You can see the flow, you can document it, and you don't have to inject the dye. Unlike what the fluorescein angiography shows, angio-OCT, we can do the segmentation, we can do three-dimensional imaging, that is NFAS imaging we can do. So when we do angio-OCT, we have two plexuses, which is superficial and deep. We all understand about the superficial plexus because that's what we are used to. Regarding the deep plexus, we are still interpreting. When we apply the angio-OCT in diabetic macular edema, we do see more and more of areas of capillary non-perfusion in the central block. But regarding the microaneurysms, we still see only 30 to 40% of the microaneurysms on angio-OCT. Whereas if we are seeing, what I mean is if we are seeing 100% on fluorescein on angio-OCT, we identify only 30 to 40% of them. And we have a study going on by Giovanni Storangi and all of us involved, where we are realizing that we don't see so much of microaneurysm. So when we are talking about angio-OCT, we are too new right now to base our decisions based on this, but yes, it does shows more areas of these dark areas of capillary non-perfusion, and you have to decide how to manage them. So when we come to the diabetic macular edema now, we all heard that ranibizumab is the thing. And when we are talking about the center involving macular edema, we do realize injections is the treatment. And here is the center involving edema. You don't actually have to do the fluorescein. You just do, this is what I was saying, this is the NFAS OCT image, which you generally have to see the exact morphology of the lesion. And this is the B scan which we are all used to. So we do see the cystoid spaces, and NFAS you can see the cystoid spaces, and you do see that these cystoid spaces are involving the center. But if you're looking at the angio-OCT, it is not showing any of those spaces. So all these multimodal images have to be combined to see exactly what you are dealing with. And this is the same patient which is on angioflow, which is now we have gone on to our segmentation level here. Our slab is at the outer retina. We can see there is this area entirely corresponding to this, but NFAS OCT also shows there is area of some capillary void as well as edema. So would you consider laser? Not really. These are not the kind of the patients you would do laser. You would give anti-VEGF, you would try to reduce the thickness, and then you would do laser if required. Now, in a country like ours where you would repeatedly hear that ranibizumab is not for us, we can't give multiple injections. So first, let's think that what are we trying to achieve by treating macular edema? So our first aim is to initially prompt reduction of the retinal thickness, because we don't want our photoreceptors to be detached for a very long time. We want them to get back to their normal position as quickly as we can. This we can achieve by giving the injections, but our aim is also to minimize the number of the injections. And once we have achieved the reduction with the help of pharmacotherapy, we want to maintain that reduction without needing to repeat the injection month after month. So we have to look for the effects of doing it. Logically, you reduce the thickness by giving injection and do laser for a long-term follow-up. But we also want to minimize the side effects of the laser. So what does the logic say? How to achieve all these things? The logic is very simple. The results of the clinical trials indicate that therapeutic effects of intravitreal are very short-lived compared to the laser. So the protocols that combine the two and compared, they are all showing that laser was still has a long-term effect compared to the pharmacotherapy. So frequent injections are needed to treat the diseases which are chronic and recurrent. So how do we do? Which laser should we use? We have subthreshold laser treatment, which is easy to deliver and not associated with any of the serious complications of intravitreal injection. And in our country, we have the unique problems of intraocular injections. So what would be the current PPPs for us? I said it already. I'm not going to repeat it. Let's move on. Can laser help us in reducing the VEGF load? Because when we are talking about anti-VEGF, is there any way we can reduce the anti-VEGF load? And what Ajay mentioned and Dr. Atul mentioned also, that VEGF is coming not from the macula, but it is coming somewhere from the periphery. So now we have a way of looking at the periphery by looking at the wide field fluorescein angiogram. And when we see the wide field angiogram, we do realize that there is macular edema, fine. But this macular edema is coming from ischemia, which is not in the macula, which is far, far away from the macula, and which is somewhere here. Now, this is what we were missing out earlier. Like earlier, we used to say diabetes involves the posterior pole, which really not so. We are managing anti-VEGF by giving ranibizumab, which is working beautifully well. But we have to take care of this source, which we can do by doing the targeted laser photocoagulation. And we have two publications now with Jay in IOVS and AGO about the role of TRP as a long-term follow-up once you have achieved the initial maintenance with the anti-VEGF. So now we move on to the next aspect of my talk, that is the role of the navilas. So what is exactly the navilas? It is one of the lasers which we prefer for using the macula. Now, why do we want the navilas treatment? I will show you what happens when it is inadvertent or somebody inexperienced does the treatment for the fovea. You might end up in a scar like this. And this is what normal adaptive optics would show. This shows beautiful rod and cone mosaic. And this is what we have achieved with this scar. So we have totally knocked off the photoreceptors in the center because of whatever reasons, because we had an inadvertent burn in the fovea. And when the macula is edematous, we sometimes tend to go high on the power and we may permanently cause the damage. So that is what is against the normal laser. So what is navilas going to do? Here is the conventional laser. You do fundus photo, you do fluorescein on whatever method you have, you do the focal laser, but you don't have a plan. and you may give topical contact lens, and then you do the focal laser. How is Navilas different? You do all this on the system. The patient sits there, it has a camera, you do your photos, you do your angiography, you plan your focal laser, and then you tell the machine that this is the area I want to do, and the machine does it for you. This is how it looks like, the Navilas laser. So what do I do? This is the area I want to protect. I will first put a marker here that please don't laser this area. If you are doing PRP, you want to protect the disc, you can do this. Then this angiogram is done on the Navilas only. So then you mark it. You mark the areas which need to be, microaneurysms need to be treated. If you are one of those who treats OCT, you can do that also. You can have the map, you can mark the area of the map, and this is how you can mark this area in a grid shape pattern if you want to use, using a modified grid, and these are the areas which would be protected by the eye tracker. You shoot the laser, you are not doing anything, there is no lens or anything, patient is looking straight, machine just keeps on ticking on them, and it keeps on telling you that these burns have been shot, and this is the follow-up of the same patient. So Navilas gives you a clear-cut guidance, protection of vital structures, eye tracking, digital documentation with consistent application. Coming to the third part of my talk, which is what is the indication of steroids. It says Ozurdex implant, but it could be true for any of the corticosteroids for diabetic macular edema. Subfoveal serous retinal detachment, it's not a standardized indication, but if you see too much of the fluid, maybe you want the apposition very fast. And from I do a lot of inflammation. From our experiences in VKH and sympathetic, the best way to bring down the fluid is giving steroids. So we prefer using the steroids. I will go along the way. Now this is what I mean by a subfoveal serous detachment, a huge detachment here. This looks fine, but when you do the OCT, it's kind of scary. I know anti-VEGF would work, but if you want something in addition, this patient already had received 2 injections of anti-VEGF, and his macular thickness was more than 1,000. This is 1 week after giving the implant. This is at 2 months, so you can get a good restoration in some of the patients where the steroids work very, very fast, along with the Avastin. The second indication is recalcitrant macular edema, which means you have given laser, you have given multiple anti-VEGF, you have taken care of their systemic control, but still nothing is working. Before you decide for the vitrectomy for a non-fractional DME, steroids do help in resolving some of these cases. The third indication is that you have done a vitrectomy, but somehow the macular edema, which was existing before the vitrectomy, continues to persist for a longer time. For example, this is the patient who had a proliferative component, and he did undergo vitrectomy for the same. So this is the top one is before surgery. This is after surgery. We know we have taken care of the tractional component, but he still has a very substantial macular edema. So to take care of this macular edema, we injected him steroids. This is before, and this is 3 weeks post Ozurdex. My fourth indication is which I'm doing it. It's registered on the clinical trials where we are giving Ozurdex at the time of the vitrectomy because it helps in the early rehabilitation. This is before, and this is after surgery. Within a few weeks of the surgery, you can get the this is the example of that. This is the patient, has a taut hyaloid and lot of edema, and this is surgery done preoperatively. This is 3 days, this is 1 week. And this is within 2 weeks. You get it very anatomically normal because, I'll just take 2 more minutes, because you have injected Ozurdex at the end of the surgery. So vitreomacular traction is prevented, and Ozurdex is taking care of the pre-existent macular edema. And this is the last and I think the most important indication for us is the pre-cataract surgery. We have published it in ophthalmology where we had randomized our patient with diabetics and cataract to receive cataract surgery with Ozurdex implant or without Ozurdex implant. And these are the pictures actually from the journal which we published. You can see a good grid done before surgery, but there is macular edema, there is macular edema. There is, it seems there is a hyaloid, but on three-dimensional, it was not tractional kind of a macular edema, and this is post-operative. So unlike the diabetics who remain so unhappy in the post-operative period, giving an implant sorts that problem out. You can see this is the cataract is out and his macular edema has responded beautifully. So to conclude, nutshell treatment of the peripheral retina, we are getting the mixed reports whether peripheral retina helps in the management of macular edema or not, but it certainly helps in reducing the number of the injections required for the macular edema. Then Navila's targeted laser treatment is effective, safe, and for the youngsters and for the inexperienced, it can prevent the inadvertent macular burns. I'm not touching about the rejuvenation therapies and all because Ajay is going to talk about micropulse. And steroids in select situations, once you have seen the IOP and everything is normal, is still a very good tool. Thank you very much.